Good morning, everyone. My name's Robin Jones. I'm an orthopaedic registrar at Torbay Hospital, and I'm here to present a short case series on the Torbay Proximal Humeroplasty, or ToPH procedure. By way of introduction, proximal humerus fractures account for approximately 5 to 6% of all fractures. They're the third most common fracture in over 65s, with a preponderance towards females more than males by a factor of approximately 2 to 3. Generally, they're an osteoporotic fracture caused by a fall from standing height, and the incidence of these fractures is increasing. Our management in recent years has trended towards non-operative following the release of the PROFA trial, which suggests that only a select group of these fractures is likely to benefit from surgical intervention. So what is the ToPH procedure? It was developed to treat three-part proximal humerus fractures with a specific pattern characterized by valgus impaction of a joint surface fragment and a subsequently displaced greater tuberosity fragment extruded laterally. Anatomical reduction of the joint surface is desirable, but risks disrupting the medial hinge and increasing risk of AVN in that joint surface. The GT, however, must be reduced to restore rotator cuff function, and the ToPH procedure seeks to balance both of these considerations. So, the joint surface is left undisturbed in its impacted position to maintain the medial hinge. Control is gained of the displaced GT fragment, and then a 1 cm wide segment of lateral joint surface is carefully excised using an oscillating saw. The GT fragment is subsequently reduced into the cavity you've made and held in place using fixation of surgeon's choice. Locally, we tend to use Phylos locking plates. On the right of your screen, you can see a radiograph showing the segment which we excise laterally on the joint surface. And in this series of radiographs, you have pre-operative and post-operative appearances, AP and lateral, following fixation. Regarding results, we performed a retrospective review of our upper limb trauma database and identified every patient that had undergone a ToPH procedure. Having identified these patients, we reviewed their notes and imaging for complications and further surgical intervention, and then carried out telephone follow-up with all of these patients that we could contact. We recorded patient-reported Oxford shoulder score and patient-reported active elevation and abduction. Radiographs, crucially, were not performed as our data was collected at the height of the COVID pandemic, and exposing patients to risk by attending hospital was deemed unacceptable. 15 patients were identified between 2014 and 2020, although unfortunately 7 of these were lost to follow-up or uncontactable by telephone. The mean age of our remaining cohort was 59 years, with a range of 39 to 76. The mean hospital follow-up was 6.5 months, with a range of 3 to 13 months, and our mean telephone follow-up was 20.5 months, with a range of 3 to 42 months. The mean reported Oxford shoulder score was 42, with a range of 27 to 48. Mean max elevation and abduction were 129 degrees and 120 degrees respectively. Both of these values had a range of 90 degrees to 180. No instances of radiological AVN were reported prior to discharge from outpatient clinic, and only 1 patient underwent further surgery, and that was privately for a gliding plane release to improve their range of movement. So in conclusion, the ToPH procedure is an easily performed, head-sparing and perfusion-respecting fixation technique for valgus-impacted 3-part proximal humerus fractures. Our results are satisfactory in the context of this limited case series, with satisfactory patient-reported outcomes and no formally recorded instances of AVN, though obviously further investigation is required as we have small numbers and no radiological demonstration of our outcomes. Thank you very much for your attention. Are there any questions?